introduce Dr. Jonathan Wagner. He graduated with magna cum laude honors from Kansas City University with his Doctor of Osteopathy. He is an associate professor of pediatrics at the University of Missouri, Kansas City School of Medicine. He is also the division director for clinical pharmacology and toxicology at Children's Mercy, Kansas City. He is also the PI for the IMPROVE FALD, which is Fontan-associated liver disease, though most of you probably know that. And he holds the Mason Endowed Professorship in Cardiac Research at the Children's Mercy Kansas City Hospital. When asked to describe his perfect date, he said it would be a walk on the beach with his wife in Oregon. He specifically said Cannon Beach because it has the best haystack rocks in all of Oregon. He will be telling us about precision therapeutics in pediatric cardiology.
So can everyone hear me in the back? Okay, great. Thanks for that warm introduction there. I should have put in a couple slides from Oregon. I usually do in my talks. I'll make sure to do that next time. So thank you so much for the opportunity to speak to you all today. In full disclosure, I am not a pharmacometrician or a pharmacokineticist, despite the good Dr. Sue Rahman's effort, my T32 training to make me into one. I think she realized that it's hard to train a glorified plumber and electrician like myself. But somehow we got there, and I'll show you some of that evidence here today. I am a clinical scientist in pediatric cardiology, and every day I try to utilize the tools that I gained in my pediatric clinical pharmacology training and apply it to the bedside. Dr. Quinney asked that I present some of my past work with pharmacogenomic-driven PK projects and how I've leveraged that into experiences and into other opportunities. So this is really career development in nature. I have no, sorry, let me advance here. I have no conflicts of interest, and I am funded by several mechanisms for cardiovascular drug research, which I'll talk about today. These are some of them. So I know this slide would cause some controversy. I think everybody's tired of the Kansas City Chiefs. I am not tired of the Kansas City Chiefs at all. But I had Patrick on here to just kind of point out which direction we were going in today. So we will review my journey to precision therapeutics, some of my early career work with PGX, PK, why non-pharmacogenomic factors may be just as influential, and how these skills have helped me extrapolate to other cardiovascular diseases. So my love for pediatric cardiology started in 1987, maybe before some in the room were born. When I was on my brother's school field trip to Chicago, we toured what is formerly known as the Sears Tower, the Navy Pier, got deep dish pizza, Lou Malinati's for all those that keep track, Giordano's, that doesn't exist in our family. But to this day, the most impactful part of the trip was seen here at the Museum of Science and Industry, where they had a life-size model of the heart where one could really explore the four chambers of the heart. So I knew from that day forward that science was going to be for me. However, in the second grade, when I penned my Student of the Month, gym class was still #1, and my pursuit of becoming a professional football player was still intact. Early in my life, though, one individual solidified my desire to become a physician, to leverage science into something good. My own pediatrician, Dr. Abraham Phillips, which retrospectively, he looks a lot like Steve Buscemi here, so don't let that distract you. But he was thorough yet funny, crazy yet serious when he needed to be, but he was dedicated to his craft, even seeing patients in the office on Sundays when a panicked parent needed reassurance. So in 1990, I penned my Student of the Month, 4th grade now. I still liked football. Bo Jackson was my favorite athlete, but I had put my football career aside, wanting to become a pediatrician. collectively, it was Dr. Phillips that really was the first person in medicine I looked up to. So I knew I wanted to be a pre-med. My senior year of high school, Mizzou representative told me and sold me on a biochemistry degree to make me more diversified and competitive for medical school. I had no idea that those foundational skills would ultimately come back to my current research focus of pharmacology. While I was at Mizzou, I got my first experience working in a basic science laboratory. Under Dr. Mark Martin, we explored the GA binding protein and its role in mitochondrial transcription factors responsible for mitochondrial energy metabolism. I successfully contaminated the lab 3 times during my stint there, but fortunately have never contaminated a lab ever since. On the weekends, I worked at Boone Hospital Center where I learned from nurses, pharmacists, clinicians on how to become a truly great advocate for patients. So my journey took me 2 hours west to Kansas City after that. As fate would have it, actually, during my cardiology section in medical school, my cousin delivered a brand new baby boy, but a thorough evaluation discovered that he had Al Kappa. Al Kappa is anomalous left coronary artery off the pulmonary artery. Fascinated with coronary artery anomalies could actually happen in pediatrics. Took me down many rabbit holes to learn about congenital heart defects. So really, besides some really basic science exposure in my undergraduate time, I essentially didn't have a research focus, and I didn't think I would be a clinical scientist. So my first pediatric rotation was on the blue team, ironically, at Children's Mercy, Kansas City. That was the Pediatric Cardiology Service. My first attending was Dr. Steve Kane. He was our chief of interventional cardiology, a Kansas City icon. He was the first person I looked up to at Children's Mercy. So I stayed aboard for residency there in pediatrics. They didn't have a pediatric cardiology fellowship at the time, actually. So I proceeded to go 15 hours east to the sweetest place on earth, Hershey, Pennsylvania, for the first year of my cardiology fellowship. There, I really honed in on a lot of my clinical skills, where we looked at the many different aspects, but my research was not pharmacologic in nature. Actually, we looked at neurodevelopmental outcomes of cerebral embolization through intraoperative transcranial Doppler, which was the standard of care for bypass cases at Hershey. Like all pediatric research, of course, the sample size was small, only 24 patients included. There were only a few correlative analyses that were really drawn from this study. My program director at the time, Dr. Devyani Chowdhury, who was another giant in my field, really encouraged me to fight for my patients, both academically and clinically, words that certainly I still remember today. And she was certainly the first cardiologist outside of Kansas City that I looked up to. So now we're getting to clinical pharmacology finally. So as things changed in Hershey, I had the opportunity to come back to Children's for my second and third years of fellowship training. I had a research project under my belt, but truly needed a project to really push my career forward, something that was hypothesis driven so I could really sit for my pediatric cardiology boards. So Dr. Kane, my program director at Children's Mercy, he encouraged me to have a conversation with this guy, Steve Leader from Clinical Pharmacology. What started as just a solicitation for a research project advanced to an additional T32 fellowship training. That was a great conversation to come home to my wife that I signed up for an additional fellowship while I was at work that day. But I saw it truly as an opportunity because there was so much knowledge that we did not have at our grasp in pediatric cardiology from a pharmacologic sense. So I knew that there was a great opportunity that rose there. So I started with a project evaluating the pharmacogenomics of statins in kids. It was low-hanging fruit. It was supposed to be one single project that really developed into a program. So I quickly became acquainted with the protein called OATP1B1 encoded by the gene SLC01B1. And this took me down a series of pharmacogenomic-driven statin projects where we were the first group to characterize this pharmacogenetic effect in kids. However, to be honest, I wasn't at the time completely content with the statins. A decade later, I am still working with the statins, but I feel like I still had something more to offer pediatric cardiology. So let's get into this work a little more granular level about our statin PGX stratified PK studies. So, and give you a little bit of clinical background. In 2011, a large shift occurred when the guidelines changed, recommending a universal screen for dyslipidemia in all children. Due to this enhanced screening and our ongoing childhood obesity epidemic, we are left with a significant number of children that would actually qualify for a statin. And overall, children and adolescents do respond to statin therapy. However, that degree of response is highly variable. So pravastatin, for example, has an average of about 25 to 35% LDL reduction from baseline in these existing pediatric efficacy trials. But the variance was pretty high, almost a 3 to 4-fold range of response. We saw this with other statin agents as well. So some of my clinical colleagues fought back about precision therapeutics. They said, 3 to 4-fold range of response may be compelling, but statins are a relatively benign drug, rare side effect profile that's reported in the short duration pediatric studies. Now, as a cardiologist, there's no doubt about it. I'm worried about atherosclerosis and intervening on that for our kids. But as a pediatrician caring for the whole patient, I worry about the risk of statin initiation in the developing child. What are the long-term effects to the brain, skeletal muscle, or sexual maturation? The other point that was raised in critique was, as a provider, can I just simply titrate to effect? Why do I need precision-based care? But as providers, point of care providers, is titrating to effect really appropriate anymore? With all the technology, with all the modeling, with all the omics that we had at our hands, why don't we just get the right drug, the right dose right away? So at our institution, we will admit pharmacogenomics is really important, but it's not the only component of precision medicine. And Dr. Leader, my former mentor, colleague, really coined the Goldilocks paradigm for the research program there. It is a platform to deliver precision or individualized based pharmacotherapy to children called Goldilocks. We have expanded that program to a clinical consultation service, both inpatient and outpatient consultation service as well, some of which involves pharmacogenetics, some of which involves therapeutic drug monitoring or adverse drug reactions. But ultimately, the goal of the program is not too big, not too small, but the medication that's just right for your child, just like the Goldilocks paradigm. This takes into consideration every factor that makes every child unique. We all know ontogeny or stage of development is important. Genome obviously is important, but for our cardiac kids, I add in the physiologic state, diminished cardiac output, elevated pulmonary vascular resistance. Now, this is a concept that everyone in this room understands, but I will tell you, as a clinician, prior to my clinical pharmacology training, a lot of clinicians don't understand the dose exposure response relationship. I understood dose response. And in my clinical pharmacology training, I really took home the point, interested in pharmacogenomics, that we couldn't do an exhaustive evaluation of the drug target unless we understood the exposure. But it is important to know what the therapeutic goal of drug administration is, what exposure is required to achieve that desired response, and then finally, what's the dose to be administered to be effective. So this is where I started my research program back in fellowship, led me down a series of projects that I showed you earlier involving the statins. One of the largest sources of variability of statin exposure amongst adults was related to a protein called OATP1B1, coded by the gene SLCO1B1. And seen in this animation to the right, after absorption, this liver-specific protein is the conduit by which statins are transported to the active site within the liver to disrupt cholesterol biosynthesis. However, if there exists variation of the SLCO1B1 gene, statins undergo less uptake into the liver, leaves a far greater concentration in the plasma, as seen here. The consequence of this increased plasma concentration being more peripheral tissue exposure, causing toxicity, the most common being myalgias. Additionally, arguably, there is less statin within the hepatocyte, potentially to disrupt cholesterol biosynthesis. So for those of you who don't know OATP 1B1, many of you are probably familiar with. It's a 691 amino acid glycoprotein that has an area of interest here with the red arrow that I've delineated. This shows the 521 T to C allelic variant in exon 5. This variant is associated with decreased expression and functionality of the transporter. This table will become of a little bit more relevance when I describe our in vitro uptake experiments that I performed with Dr. Bruno Hagenbuch at the University of Kansas during my K award period. But one should know there are some haplotype nomenclature and assignments that are out there. For our study in the PK, we used the 521 allelic variant. But for reference, star 1A, star 1B, associated with normal expression and function, star 5 and star 15 with diminished expression and function. So the question I had based off the table that I showed you earlier with pediatric statin response and the poor response in a subset of patients was it really poor statin to drug target engagement? Or was it simply inadequate hepatocyte concentration of the active drug? And it was really this concept of variable transporter uptake that was the first area we wanted to understand in a pediatric cohort. In the adults, by much of this work by Mikko Nemi's group out of Finland, they demonstrated the genotype-phenotype relationship that you can see in the PK profile to the right. So those with only one functional allele are those with 521TC genotype assignment compared to those with 521TT in the black lines there. Prior our study, the only pharmacogenomic-driven statin study in kids actually reported a higher pravastatin exposure or plasma concentration in the TT group, which is delineated by the white circles here. It was a really small study, only 9 children, 6 TTs, and 3 TC patients. So it needed to be replicated in a larger cohort. So this led me to work with one of my most influential mentors, Dr. Sue Rahman, who taught me the rigor of assessing pharmacokinetic profiles, QCing the data, analytical chemistry, perfectly vetting this pediatric data, because it may ultimately be the reference standard for the future. So she lit a fire under my ass to make sure it was right. So our study in a larger cohort of 32 children and adolescents confirmed the genotype-phenotype relationship as observed with adults. And this is seen here in the box plot in the center of this slide. So those patients having less functional transporter, or those having 1 or 2 C alleles having less hepatic uptake, larger AUCs, which is very similar to the animation that I showed you before. However, these are just the median values, and actually the mean values, sorry, I left that off of this box plot, are near where the median values are. That was significantly different. But this is just the mean. When I placed the AUC values of the individual patients on the box plot, it certainly told me a different story. For instance, this patient in the TT genotype group had exposures near the upper quartile of the TC group, even though they're of TT genotype. So does SLC01B1 genotyping alone really help for the clinical care of the individual patient? Now, for the entire cohort, there was an 11-fold range of pravastatin exposure, so highest to lowest for the whole cohort. Even when we divide amongst genotype groups, highest to lowest, 11-fold range for the TC group, 11-fold range for the TT group. So even though the means and medians are different, overall, we cannot conclude by SLC01B1 genotype alone that it characterized the variability. Yes. They are. So OATP1B1 is the protein. The gene is called SLC01B1. There's a lot of debate in the community that the gene should be named OATP1B1. I'll leave that discussion for the PGRN, though, to discuss. And if we want to talk about it at the break, we can. Great question, though. All right, so let's move on to some of the non-pharmacogenetic factors. So To illustrate the challenge of applying really one single genetic test to predict exposure and inform dosing, I wanted to focus again on this pravastatin exposure box plot and really hone in on the TT group, where there was that 11-fold range that was observed. You see that a majority of those dots or those individual patients are essentially between the 50 to 100. What's driving a majority of the intergroup variability are these four outliers in red. Perhaps for the TT group, if we could figure out the unique characteristics of these patients, we could more reliably predict the exposure, at least in the TT group. So we sequenced the entire SLC01B1 gene, looking for rare polymorphisms. It was negative. We looked at alternative transporters. OAT7, actually, pravastatin was the first substrate demonstrated for OAT7. We sequenced that gene. We didn't find anything of functional relevance. In the 521TT group, though, the only demographic parameter that was found associated with pravastatin exposure was weight and BMI. And in fact, the figure to the bottom right, when we plot pravastatin AUC versus the BMI Z-score on the x-axis, you can see, once again, majority of those patients, 50 to 100, as you progress from the left-hand side to the right-hand side of the figure, until we get to a threshold value of about 2.5, where there's a dramatic increase in exposure. Now, obesity associated with fatty liver disease in mouse models as previously demonstrated. It's associated with downregulation of transporter function, irrespective of genotype, highlighting for me as a part of this project that we have to look beyond just pharmacogenomics for precision-based care. So could liver fat be the culprit explaining these findings? So those variables have led to a current clinical trial where about just over 50% the way through enrollment that evaluates the impact of liver adiposity on pediatric statin transport and response. And these two aims test the hypothesis that liver adiposity quantitated by liver MRI is associated with diminished hepatic uptake and less statin response. To quantify liver fat fraction, we actually use an MRI PDFF technology, proton density fat fraction. So unlike liver biopsy, obviously MRI is novel, non-invasive, and is safer for a pediatric cohort. It has high correlation between MRI and steatosis on liver biopsy. So what about the TC group? So we had an 11-fold range in TT. We have maybe an idea of what's going on there. What about the TC group? 11-fold range that we observed. Well, pravastatin is administered in its active form. It's not metabolized by cytochrome P450s, which lowers its potential for drug-drug interaction. That's why it's the preferred agent in our post-transplant population. However, pre-systemically, it can be converted to an inactive isomer called 3-alpha isopravastatin. Structurally, it's similar to pravastatin, but the hydroxyl group has been rotated from the 6' to the 3' position, deeming it inactive. Now, Dr. Triscari and team members at Bristol Myers Squibb that developed pravastatin demonstrated in the figure to the bottom left a nearly 5-fold increase in the non-enzymatic production of 3-alpha acid when pravastatin was directly administered via nasogastric tube to the acidic environments of the stomach, as opposed to the more alkaline distal portions of the small intestinal tract. What was interesting was the amount of 3-alpha pravastatin that was recovered in our patients. The box plot to the right represents 3-alpha pravastatin AUC, and it really looks pretty similar to the pravastatin box plot to the left. However, we really observed that the degree of conversion to 3-alpha acid was quite variable amongst the study cohort, representing an important source of, we think, inter-individual variability in pravastatin exposure in addition to genetic variation. So the relative formation of 3-alpha acid was determined using post-dose pooled urine samples, and we displayed that as a percentage of total analyte recovered on the x-axis, and pravastatin AUC as our dependent variable on the y-axis. So within the entire cohort, the pravastatin AUC decreased as the fractional recovery or rate of conversion increase with an R-square value that was pretty small. Within a genotype group, however, there was a stronger relationship observed for the 521TC group R-square value of almost 0.6 relative to the TT group, minus those outliers that I showed you before, where it was simply just a straight line across. So isomerization seemed to have a stronger impact on the TC group. So the clinical consequences of enhanced isomerization of pravastatin and 3-alpha acid is diminished pravastatin systemically and potentially subsequent delivery to the hepatocyte. Now, our genotype-phenotype data suggested that 3-alpha acid is likely a substrate of OATP1B1. My question was, if it was a substrate, could there be a potential for competition occurring as well? So that led me to a place where I wanted to explore in vitro drug transport and test my hypothesis of whether 3-alpha pravastatin could in fact be a substrate for OATP1B1, but also inhibit pravastatin uptake. So I went to the 4th floor of the Hemingway Building, the University of Kansas Medical Center, and worked with an international OATP1B1 expert, Dr. Bruno Hagenbuch. Was only 10 minutes away from Children's Mercy. Was very lucky to have that in my backyard. So we took a look at this paradigm and wanted to not only demonstrate whether it was a substrate, additionally, we wanted to confirm if this was more significant for those genotypes associated with decreased expression and function, namely the STAR5 and STAR15. So we generated those plasmids of interest and performed a series of uptake experiments in the HEC293 cell line. So in vitro, we characterized what was already known in vivo, where transport function and expression was more robust in the STAR1A, STAR1B genotype relative to STAR5 and STAR15, with intrinsic clearance being much higher. Same thing demonstrated for 3-alpha acid with an intrinsic clearance that was much higher for those of normal genotype versus those that were not. So the final phase, we performed 1-minute pravastatin uptake with increasing inhibitors of 3-alpha acid and performed this again in the same cell line, transiently transfected. IC50 values were calculated by non-linear regression analysis, and we summarize that on the table here. So 3-alpha acid inhibited pravastatin uptake for all protein types, but was more influential for the STAR5 and STAR15. As you can see here, a much lower IC50 value compared to the STAR1A, STAR1B. So we confirmed that 3-alpha acid was a substrate of OATP1B1, and it certainly could inhibit uptake, but it was more significant in the variant proteins. So the question comes up, is there a need for formulation change in the future? So moving on to just extrapolation in the last few moments here into other disease processes. So I feel like my career was progressing along pretty well. I found a niche within statin optimization. But during the pandemic, I went to a parents forum within our heart center. And I was talking to them about precision therapeutics, optimization, what our group does in clinical pharmacology. And the parents, every single one of them just raised their hands. They're like, can you do this for our child with other drug substrates within our subspecialty, whether it be antiarrhythmics, phosphodiesterase inhibitors, and other drug substrates? And it really made me ponder deeply about my career trajectory and if I needed to have a pivot. So as I was finishing up my KL2 work, my division director at the time, Dr. Girish Shirali, nominated me or voluntold me to be the site PI for a pediatric heart network study called the Fontan Udenafil Exercise Longitudinal Trial. It evaluated a phosphodiesterase inhibitor, Udenafil, 87.5 milligrams twice a day over 6 months to a cohort of 12 to 18-year-olds with Fontan circulation. At the time, I can tell you, I wasn't completely thrilled with it. I felt like I had a lot on my plate. But as an early career faculty member, I knew better than to say no to your division director. However, what I realized was that Dr. Shirali was putting me in a position to be involved in a multi-center trial so I could showcase my ability to organize, execute clinical trials. from a study sponsor. So the study did show, based off of exercise testing, some improvement in children that were dosed with sildenafil compared to placebo, improvement of oxygen consumption during peak exercise, which is really a marker of exercise tolerance. However, the p-value was set at 0.05. It did not meet significance. So there was a trend towards improvement for this study. So as we wrote up the publication, and I was on the publication committee, I mentioned, hey, we're using a fixed dose of 87.5 milligrams in 12 to 18-year-olds with a varying range of weight. Can we adjust these findings for milligram per kilo basis? I was told that's a great idea for a secondary paper or another writing committee, but not for the primary paper. And it drove me crazy. I'm like, no, we have to have this in the primary paper. This is going to be the reference point. So I was definitely dejected, but it taught me a lesson, even with my unique skill set in pediatric cardiology and clinical pharmacology. If I wanted to play with the big boys and girls, I would have to have a seat at the table, and it needed to start with me, and I needed to start my own Fontan research. So a little bit about Fontan as a background. It's the third and final stage of a series of palliative surgeries for those with single ventricle congenital heart disease. With nearly 70,000 patients worldwide, nearly double that amount expected in the next decade, really a lot of efforts to predict, prevent, and treat cardiac and end organ sequelae of the Fontan circulation is imperative in our field. The Fontan operation creates a unique circulatory pattern. It has passive systemic venous return of deoxygenated blood to the lungs. So there's not a subpulmonary pump. Over time, this passive system, unfortunately, leads to elevated pulmonary central venous pressures, elevated pulmonary vascular resistance, hepatic venous stasis, congestion, and subsequent liver fibrosis and cirrhosis, known as Fontan-associated liver disease. In contrast to adult cirrhosis disease, FALD represents a congestive hepatopathy with a variable combination, though, of liver congestion and fibrosis. Despite investigations to diagnostically evaluate FALD clinically through biochemical or imaging assessments, this is not consistently correlated with intrinsic hepatic function until it's severely impaired. So although liver stiffness, as quantified by MRI elastography, was associated with model for end-stage liver disease score, or MELD score, in a small cohort of Fontans, it remains unknown at what liver congestion and fibrosis thresholds intrinsic hepatic function, such as drug metabolism and drug transport, begins to decline in patients with Fontan circulation. So this led to the objective of our current pilot study. It's funded by the Imprint Opportunity Pool, and we want to determine the role of Fontan-associated liver disease as on two independent drug disposition pathways through a single dose baseline pharmacokinetic study with administered probe substrates. We selected sildenafil. It's a common agent that sometimes is utilized in this patient population as a probe for 3A4. It's also on the BPCA list, in addition to pravastatin, given our experience with this drug substrate, testing OATP1B1, another agent that's on the BPCA list as well. So I hope over time we'll provide you an update of this pilot study with the Imprint Hub when we discuss this, but just to kind of set the table for you in the future, this study aims to look at the contribution of liver congestion and fibrosis on hepatocellular drug metabolism and transport in the Fontan circulation. The MRI technology we're using for this study is a 4D-flow MRI. So what 4D-flow allows us to do is really get the congestive component of this process. MR elastography is great, but it is really a summation of both congestion and fibrosis. So we're going to obtain both of those during the study to really tease out the congestive, the fibrotic component of it as well. We are going to test PDFF as well. Most of these patients are not obese, but we are going to quantify the liver adiposity as well as a secondary analysis. All right, round in the corner here, almost done. Just a few parting words of advice for the trainees in the room. So I placed this picture intentionally, being in the Hoosier State. I had to get Coach Norman Dale on there, but during the movie, he always says, team, 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 team. The most important part, I think, of building your program is to work collaboratively with a diverse group of individuals. I am not the smartest person at the table, but collectively, our program is brilliant because we bring in a lot of different ideas. Second, don't overlook opportunities. Whether it be a multi-center trial from your division director, a collaborating clinician, look at those opportunities, seize those opportunities. Thirdly, invest in yourself. First and foremost, you're going to be your best advocate, but later on, be that voice for your mentees. And then finally, we all need our well-being. And as corny as it sounds, and our cardiology fellows hate hearing me say it, learn the systole or the hard work of life, but also learn the diastole, the relaxation. Find those things that find you and bring you joy. So finally, my last piece of advice, find a great mentor. Or for me, I found several. All these leaders had an impact on my future. They helped cultivate the person who I was. But I will say my most important and influential mentor was my dad. He passed away last year. And as I reflected upon him and what he instilled in me, the most important thing that he instilled upon me, being a school teacher and high school coach, were those principles of teamwork, hard work, and really building personal relationships. And then finally, anyone that wants to talk about further training in clinical pharmacology and pediatric clinical pharmacology, we do have a T32 fellowship that's focused just on the pediatric side of things. There's a QR code for anyone that's interested. I have some information after the talk if you want to hear more about it. And thank you.
Thank you, Dr. Wagner. We have our first question.
It's not a planned question, I swear. I'm just genuinely curious. Is FALD graded or scored like cirrhosis? And how are you going to integrate the degrees of dysfunction in your trial?
Okay. Great question. So I'm going to back up to this. I'm going to add in number 5. Okay. Don't invite your former mentor to your talk to bust your chops. Okay, I'll answer the question now. We don't know. That's the challenge that we have with Fontan-associated liver disease. Really, screening for Fontan-associated liver disease really has occurred over the course of the last 5 to 10 years. As these children got older and they were surviving into adulthood, our adult congenital counterparts were observing hepatic dysfunction, but it was advanced at that point. So much more of the emphasis is on screening at an earlier stage, which we do a better job of now. There is a 1 to 5 scale that is somewhat similar to adult cirrhotic disease. Many times we use the MR elastography as our score. The challenge with that, though, again, is a combination of congestion and fibrosis. And what is that patient actually dealt with at that stage of their life or their years post-Fontan?
Excellent presentation. That was great to see your path through that. I'm just curious about the choice of pravastatin early on because, and I could be completely wrong on this, but I thought the association was lower with that, at least in adults, with SLCOB1 genotype and toxicity with that.
Yeah, so that's another great question that we kind of deliberated about at our institution of which one we should really use. Pravastatin is predominantly a substrate for OATP1B1. Rosuvastatin is a substrate for OATP1B1, but also 1B3 and NTCP. So we had thrown that one out. Simvastatin, and I didn't get time to show this in our experience. It was actually the most variable statin in terms of exposure in the series of projects that we did. Actually, it was almost a 17-fold range. So given the variability that we observed for that agent for a number of reasons, we chose not to select that one either. So we're pretty much down to atorvastatin and pravastatin. We could use pitavastatin as well, but it's not as utilized in the pediatric population. Atorvastatin is metabolized by cytochrome 3A4. So we wanted a substrate that was not going to undergo CYP-mediated metabolism and wanted to keep it as a pure OETP 1B1 probe substrate. So that's how we settled on that one.
Okay, great. Kind of as a follow-up then, and I know you described very well the importance of exposure and everything, but I got of course asked, did you look at outcomes as well with genotypes? I just wonder if LDL or if there was any toxicity that you measured and if there was any association that among the genotypes as well. And I know you had a small population, as you mentioned.
Yeah, so we did have a small population, and it was just a single dose PK study. So really to look at the best marker is LDL cholesterol, and that is more of a longitudinal marker. So certainly accelerating this into the future, we would look at that in a longitudinal fashion. However, we actually just sent off a secondary analysis for these patients that participated in all 4 of these PK studies for metabolomic analysis, just to see if there was anything immediately from a response pathway perspective and cholesterol biosynthesis pathway. And as one would expect with metabolomics, where it gets pretty extensive, we're still digesting that. So we're hoping that it'll at least give us some indications of that PD biomarker that we can use in the future more longitudinally.
All right. Thank you again, Dr. Wagner.
Thank you.
We're going to take a roughly 10-minute break. If you want to try and be back here by around 2:15, and then we can get started again at about 2:20. Thank you.